Okay, so we have a case of a 43-year-old lady. She has known metastatic melanoma, and she was referred to the oncology team for tiredness, from the oncology team, to the endocrinologist for tiredness and a low TSH level. Her past medical history includes a melanoma, which was resected 4 years ago, plus lymphadenectomy. It was it was lymph node positive, yeah, but she had lymph nodes resected as well. And at the end, after her surgery, she had no residual disease. Now, she had a recurrence of her disease in the lateral aspect of her right thigh 6 months ago, and she underwent a second surgery. She had additional workup at the time with positive liver metastasis. Her medication involved oral contraceptive pills and vitamin D. Her social history: she's married, she works as an architect, she's a non-smoker, and she consumes alcohol occasionally. She was treated with ipilimumab and nivolumab, which were started 2 months ago. Now, the patient developed a rash after her first cycle, and she was given a cortisone cream, triamcinolone cream. After her second cycle, she developed grade 1 transaminitis, but did not require any intervention. Her TSH level before the treatment of ipilimumab and nivolumab were normal at the level of 1.1. 1 month after her first cycle, her TSH was measured and it was 0.02, but she denied any symptoms of hyperthyroidism at the time. But 6 weeks later, after starting treatment, just before the first cycle, the third cycle, she had a TSH of 0.3, and she started complaining of tiredness. That was when the oncologist referred the patient to the endocrinologist. Now, we had an extensive talk about what would be the differential diagnosis of a lower TSH. Is anybody that would like to express an opinion on that? Great, I'm going on then. So, should I analyze a bit the differential? Yeah. Okay. So, a low TSH, very briefly, could be either an indicator of a primary or secondary hypothyroidism. It could be either due to a hypophysitis, or it could be due to primary hyperthyroidism, either Graves' disease or thyroiditis, destructive thyroiditis, for example. Yeah. So it's for us to differentiate what is actually happening. What further information would we ask from the patient's history, clinical exam, or laboratory investigations? Any suggestions?
If she had any radiological evaluations using contrasts which contain
all right, from her history. Yeah, that's very important. Any other ideas? Yeah.
Just a stupid question. Is she taking oral contraceptives at 43 years old with melanoma? If I well understood.
She is. We're not clear about that. We're assuming that one of the reasons might be that she wouldn't like to become pregnant.
43 years old, melanoma, and she's taking oral contraceptives.
Yeah.
Yes, but
she could still have periods.
She risks some damages. Having cancer and 43 years old, I wouldn't give oral contraceptives.
Yeah.
Just this comment.
There were some reports that melanoma can be estrogen dependent. This is why the question.
Yeah, the microphone.
I understand your point because, like,
10 years ago, there were suspects. We suspected that melanoma can also be estrogen dependent, and this is the point, right?
Not only, it's a
Thrombosis.
cancer. It's a climate of thrombosis, embolism. So at 43 years old, I would hesitate to give oral contraceptive.
Yeah,
to pursue.
your point is absolutely right. We also discussed about that, but that's the history. Right. Yeah.
Even can have an effect on thyroid profile.
Yeah.
Because on thyroid profile, because we know that estrogens have a feedback mechanism on TSH and thyroid. So I think it's a triple impact here. So we don't know where to start. Where's the head and where's the tail?
That's correct. Thank you. I'm carrying on. So this is the algorithm that oncologists have and they follow about checking thyroid function tests and also cortisol and ACTH levels based on the side effects of their immunotherapy for the cancer patients. Should I go through it? Oh, okay. They just measure baseline TSH and free T4, morning cortisol, ACTH, and then a follow-up of monthly basis for the first 6 months, 3 months for the next 6 months, and then 6 to 12 months follow-up thereafter, if everything is normal.
Why don't you do a TPO just to exclude the thyroiditis?
Oh yeah, we will do more than in TPO. Yeah, it's coming. It's coming. Right. So yeah, we did that. Okay. So with regards to the clinical examination, the lady had a pulse of 82 minutes, which was regular, blood pressure of 105/70 with no postural drop. She was afebrile, no signs of thyrotoxicosis, no goiter or thyroid eye disease. Yeah. Okay, thank you. Ophthalmopathy. Visual fields were grossly normal. From her lab results, TSH was 0.3, free T4 1.1, anti-TPO were elevated, AST and ALT were both mildly elevated. Renal function, albumin, INR were normal, hemoglobin 11.4, chest X-ray with no focal abnormality, and 9 AM cortisol was 16 with ACTH 23.6. Any thoughts on that from the audience? Great.
A case of thyroiditis.
Yeah, that's the most likely diagnosis. So what we would recommend, we recommended observation, since her results were normal, apart from the TSH, which was 0.3, and beforehand was even lower, so it seems that it's gradually increasing. But with surveillance, because the patient is very likely to develop hypothyroidism post-thyroiditis. Yeah. So the patient was checked, was not offered any treatment, was observed, and it was checked 1 month later as per protocol, and the TSH was 63.2, the free T4 of 0.6. She reported then significant fatigue, dry skin, and cold intolerance. She was treated with levothyroxine, which normalized her TFTs and symptoms. So the diagnosis was likely thyroiditis, followed by permanent primary hypothyroidism. Yeah.
If I can comment on that, I'm really surprised you didn't treat her at the first place. She was referred to you because due to fatigue, this was her main complaint. And I'm surprised since you diagnosed that as autoimmune thyroiditis, and since you have seen that TSH has increased over a certain period of time, I would give her a small dose of L-thyroxine. Yeah, but she had symptoms. Yes, we do not treat
Yeah,
results.
but she had symptoms also could be from her original disease, and with 0.3 TSH, maybe she should have checked the thyroid hormones earlier. And I can't believe that her TSH went up from 0.3 to 63 in 1 month.
Yeah.
Is this a real case?
Yeah.
Yes.
Yeah.
Wow.
That's, we talked about that we maybe the protocol was not really adequate. We should have checked it earlier.
And FT4 and FT3 were
Normal.
but within lower range.
when it was 68?
No,
No,
when it was
0.3. Yes, it was in the normal range.
Okay.
Doing the TPO. And you were late in doing the TPO.
The TPO were done in the initial assessment.
Not on the first day or the second. It was observational on the second prize.
The first TSH, the 0.02, was done by the oncologist. She was not referred to anyone. They observed the patient and repeated TSH, which came back 0.3, and then referred the patient. Then we did the TPO and all the workup.
And you have the third aspect, which is the third impact. It is the oral contraceptives.
Yeah, that's,
It can mask everything.
yeah, you're absolutely right about that.
There is no doubt about the final diagnosis and treatment, but I wonder, sodium was measured at the first time when she was with fatigue and tiredness, because these drugs and other drugs can cause hyponatremia without adrenal insufficiency.
Yeah.
Yeah?
We really talked about that because, and also about their level of cortisol, and we actually commented that the sodium would be a very good marker. And although it was not mentioned, hyponatremia, well, the level was checked. She was not hyponatremic. It was normal. Yeah, good point. Thank you.
I've seen thyroiditis in postpartum women who have no cancers, nothing else, just plain postpartum thyroiditis, go from a TSH of 0.05 or something like that to greater than 150 within a short period of time. That is not unusual for it to go to 63.
Even with this category of drugs, you see it very often in the clinical practice. Yeah, I'm not surprised because we see it very often. This huge change from 0 point something up to even 100. Yeah,
it's important.
Yeah, it's not. It's
learn.
not a surprise to me.
Yeah, we did have a patient post-thyroidectomy. In a month's time, he went to TSH 230. Yeah. Okay. Thank you very much. We'll carry on with the next.
Thank you very much for the excellent case. Thank you. Which group is on now? The red group? Red group? Who will present? Who will present? Okay, please. Load your case.
It is loaded.
So it's psychotropics induced thyroid abnormalities. Can somebody help us, please? Technician?
It's okay.
Okay, we're done. Thank you very much.
Okay. Hello from our group. We're presenting a case report. A lady with psychotropic medicine and induced thyroid abnormality. Okay. This is a case, a female, 70 years old female was presenting with tachycardia, flashing and twitching of her face, tremors, myoclons, hyperreflexia, and hyperpyrexia and an ataxic gait. In her medical examination, the patient was found to be disorientated and agitated, and she spoke with a shudder, appeared perplexed, and had prominent abnormalities in the form of alterations in the color of objects and auditory hallucinations. Now, CFE study was negative, beside a leukocyte count of 20,000, and an exaggerated amount of CPK was found. Now, her history, he had the psychotic syndrome with hallucinations, and her past treatment was with chlorpromazine, alloperivol, and fluoxetine, and now she was on misatropine. And does anyone want to tell us the possible diagnosis for this patient? No volunteers, okay.
Well,
I'm sorry, before that, would you ask for some other examinations? Yeah, all of these were normal.
Well, if I may help, all the results, the biochemical findings were normal. The only pathological findings were the leukocytosis in the CSF and the highly increased of CK. Okay, that's it.
Convulsions, the CK?
It was the yes. It has a rigidity, spasming, and then sweating, hyperpyrexia, and tachycardia, and hyperreflexia. So a endocrinologist was invited to express his opinion because a tutor there, spoken with a neurologist, has suggested to look at the thyroid, to make a thyroid functioning test. And so it started the whole story. Please,
okay.
Dr. Vassiliou.
So TSH was elevated at 78, and with low counters of T4 and T3. And the CK-MB was negative. So what is the diagnosis for this patient? Hypothyroidism. Okay, and the...
excuse me, what kind of hypothyroidism? Post-thyroid. Why?
I'm just speculating.
Yeah. We have high TSH,
low normal,
low normal T4, and low T3.
The inflammatory process is there.
It is
CK is there. Some inflammatory case coming up.
CRP
muscle level.
and sedimentation rate were normal.
I don't have it.
Were normal.
No. I'm just having the ones I got it. I'm not adding up.
But what does it speak for inflammatory disease?
Maybe it's systemic.
There was only in the CSF, in the count, the leukocytes were about 8,000, 7.8, 8,000 in the peripheral blood. The only thing, no proteins in the CSF, no bacterial infection, only a high leukocyte number. So if we started to say that it is a primary hypothyroidism, and then we turn the question to the neurologist, what is the underlying neurological disease? Any thought? What could be?
Could the patient have
Well, thyroid antibodies negative, MRI of the brain without any pathological finding.
Yes.
Excuse me?
Muscle rigidity.
No. It was a rigidity, sweating. She was deranged. She had a derailment gait, and very confused. And that in the last 30 hours, 1 day and a half or so. It was an exacerbation of an old neuropsychiatric syndrome.
What about calcium levels?
All the biochemical levels I can recall were normal. And also the blood sugar was normal. She had seizures, yes.
So CPK is from that?
Yes, okay.
Epilepsy?
But no, it was not epileptic. Because you are getting closer. Okay, maybe because of the time we can. No. The culture was negative. There was no bacterial infection. No, virus.
What was the type of cells in the microscopy of the CSF? Was it?
The only thing it was I cannot tell you. I do not remember. But the only thing that the very high number of leukocytes. But another differentiation if there was a neutrophil or lymphocytes. We proceed.
Okay, so primary hypothyroidism was diagnosed due to the level of TSH, and we could discuss if this patient suffers from serotonergic syndrome, leading to a change of her treatment.
Mm-hmm.
Okay, she was treated for the first days with thyroxine IV, and the neproleptic treatment was changed to olanzapine, which is thought to be more good for her for a possible serotonergic syndrome. And the patient left 3 weeks later with a level of TSH at 9 and a CPK normal, which was at normal values.
Almost.
Okay.
Yes. Okay.
We have to discuss
please
about
go
this
on.
syndrome.
Yes.
Okay, and the mechanism behind this syndrome is that serotonin receptor subtype 1A are being overstimulated, and one of the mechanisms that the drug that the patient was taking is that we have this excessive stimulation of type 1 receptors and the antagonistic properties of type 2 and type 3 serotonin receptors. Now, we have the thought is that TRH is inhibited by serotonin. So high levels of this hormone, serotonin, should lead to decreased values of TRH and decreased values of TSH, and this is not happening to our patient. We have the opposite. On the other hand, dopamine levels stimulate the hypothalamus pituitary thyroid axis, and this leads to TSH and T3 productions. And as Professor Tudens mentioned before, that we have some patients with hypothyroidism and depressions that are in the same region here. I'm sorry, it isn't so. So we have to think if there is an underlying hypothyroidism before. Okay.
Yes, danger.
You will have to.
Yes.
mention this.
Look, thank you very much, Dr. Vassiliou. No. It's not at the end, because there are some very interesting points here that, according to the criteria for serotonergic syndrome, there is no fever. The patient had fever. The patient had an increased CK, which are not characterized by serotonergic syndrome. And then, as Dr. Agathi pointed out, we should not expect a very high TSH in serotonergic syndrome, because serotonin might have an inhibitory effect on TRH TSH here, but we have completely different aspect. So that there is another mechanism behind. What is that? What is the differential diagnosis of serotonergic syndrome? There is a deadly disease behind, and this is the neuroleptic, I'm going a little bit quick now, neuroleptic malignant syndrome, 20% mortality. And this is characterized by this syndrome, these findings, high CK, hyperpyrexia, and convulsion, and the other part. Let's go. So we were in very dangerous waters.
Okay, and this diagram is from another patient with has to cover both of the entities, and serotonin syndrome and this neuroleptic malignant syndrome, and we see how rapid how rapid is the progression of the symptoms, and with therapy with serotonic antagonist, the symptoms go away. Okay. So the characteristic of this syndrome is, as Professor Tudas said, hyperthermia, muscle rigidity, and altered consciousness and instability of the autonomic system. The pathogenesis of the syndrome, antipsychotic drugs as haloperidol and chlorpromazine inhibit dopamine receptors, and this has an impact in the function of sympathetic nervous system, and this leads to neuroleptic malignant syndrome. Okay, so this I think this is the first case report where two patients with primary hypothyroidism developed this syndrome, and the discussion is that maybe the thyroid disease predispose to this syndrome by altering dopamine metabolism. And these are the case reports that have been reported in the literature. Okay.
And you see that haloperidol in 3 cases out of 8 it was the induced drug.
So we're in deep water with this syndrome, and the differential diagnosis was the serotonin syndrome and the neuroleptic malignant syndrome, and we have to be very careful in the diagnosis with psychiatric patients who were stable before and have a progression of their disease. We have to think about thyroid dysfunction. Okay, thank you a lot.
So this is the case of a 61-year-old woman. Oh, yes. This is the case of a 61-year-old woman with a known breast cancer who presented with diffuse osteoblastic metastasis and who we were going to treat with zoledronic acid 4 milligram IV monthly. Her treatment was on levothyroxine in this dose, as you can see here, on calcium carbonate 500 milligram per day, and on cholecalciferol 400 units per day orally. She was also on chemotherapy with paclitaxel and carboplatin, started 3 months prior to her admission. Her corrected calcium is 8.7, and you can see this is in the lower normal limit. Do you think what do you think should be our next step? Excuse me? This is the corrected calcium.
Vitamin D will be boosted up, and the calcium carbonate will be double the dose.
Should I continue? Okay.
And we don't know if she's a dairy product user.
Yes.
Maybe she doesn't like milk. Or lactose intolerant.
But milk is not so important. In osteoblastic metastases, if there are many, you can't cope with giving enough calcium, which is taken up by metastases. You can't, it's very difficult to keep calcium levels in the normal range if there are many metastases. It's a difficult task.
Okay. So the rest of her labs, you can see them here. Her GFR is 39.3. She has an impaired renal function. This is a stage 3B of renal insufficiency. She had parathyroid levels of 87. The levels of 25-hydroxy vitamin D are 24, and her magnesium levels are 1.7. Will you check anything else? Yes. The phosphate actually is not here. But in any case, okay, her phosphate levels were normal. In any case, her parathyroid levels are above the limit level, not so many elevated.
It is rebound to vitamin D, the PTH.
Yes, exactly. So we don't think there is a case of hyperparathyroidism, of primary hyperparathyroidism in any case. But yes, the phosphate levels were normal. Excuse me?
Can you use microphone and speak up? Because people can't hear you. Please, microphone or speak up very slowly. And one after another, please.
Ladies first.
Yes, the first row. Give your suggestions.
Well,
it
the
was
question
very
is,
good.
yes, okay. She has low GFR, right? And she has normal phosphate, so her renal failure has not affecting her phosphate.
Phosphate levels.
Okay, well, it's strange to me. Okay, now the question would be, with PTH 87, no big deal. I wouldn't worry about it. Yeah, this is what I'm saying. This is what I'm saying. So, could you help us with that? Regarding the
she also has a calcium level in the lower normal.
87, right?
Yes.
Okay, corrected.
So, corrected.
Okay.
So
you mean it's inappropriately low parathormone for this kind of levels should be higher up?
I would say that we have almost, let's say, normal levels of 25 hydroxy vitamin D levels.
Yes, yes.
So her calcium levels shouldn't be that low. Her calcium levels...
It's not the only...
The strange thing is that she has hypocalcemia and PTH is not so much elevated, first of all. It's
degree of hypocalcemia.
It's a little bit elevated because she has low vitamin D3 levels. That's why PTH is 87. She has hypocalcemia, so PTH should be much more.
She doesn't have hypocalcemia.
It was 7.9.
As far as I know. Well, it's low normal, but calcium is still normal.
It was 7.9.
But they said it was
lower
normal.
Calcium
okay.
levels
Lower
were
normal.
at the lower normal level. And as Professor Tiga said, she has renal failure stage 3B. So, irrespective of these vitamin D levels, 25, what we need to know is the calcitriol levels, the active metabolite. And that's what we did. We measure the calcitriol. Yes?
I would be very surprised to look at 1 alpha when, with this degree of the reduction of her GFR, has no elevated phosphate. Indeed. This is renal failure. Is she losing renal function? Okay, then this would affect 1 alpha, okay? But without affecting phosphate, without affecting anything else?
I can tell you the phosphate levels, it was the lower normal levels. And I don't know if, yes, the lower normal.
Yeah, because phosphate
Yes,
and
the lower
calcium
normal.
were used up by the metastasis. We are forgetting about
Lower
metastasis,
normal.
osteoblastic metastasis. So all the phosphorus and calcium goes into the bone. It's just sucked up.
Exactly.
And in this chronic kidney disease or whatever, it's nearly 40 milliliters. Sometimes it's not necessary that you see high phosphate or very high PTH, but with level 4, definitely. So here you can manage also with these numbers, I would say. And you won't have elevated PTH with a 25 hydroxy D of 24. With it is in nanomoles about how much? It's over 50. It's
Yes,
60.
yes,
So
yes.
no elevated PTH because of this vitamin D level. No.
Exactly, exactly.
Was the intact PTH?
Yes, the intact.
I would say PTH went up because calcium levels tended to go down because of metastases
Yes.
taking up all the calcium.
It's like a hungry bone. Yes, exactly. It's like it mimics hungry bone syndrome.
What's the alkaline phosphatase to consider the osteoblastic activity?
Let me see. I didn't put it,
Yeah.
but I have it.
Did we see it? I didn't see it.
Increased.
Ah, okay,
Increased.
okay.
I can see because we have published this case report.
That's
so we
okay.
can-
Alkaline phosphatase would make a differential diagnosis. Do you have
It was increased.
So can you go
Don't
on?
worry,
Can you
we can
proceed?
carry on.
Yes.
So these are the levels of alpha-calcidol. And
Was it still normal? Yes,
the
on the
lower
lower
normal.
level of normal.
on
Okay.
the lower normal.
Alkaline phosphatase was 209 with the upper normal 142. Elevated, 209. So you need it. That's why we ask what you need. And yes.
So zoledronic acid is used for the treatment of skeletal related events. Furthermore, is very useful in treating the hypercalcemia of malignancy. It is known to cause hypocalcemia by inhibiting the osteoclast activity. And among the risk factors contributing to the development of hypocalcemia after the zoledronic acid administration are the malnutrition, a malabsorption, a renal insufficiency, 25-hydroxy deficiency, an hypomagnesemia, and a co-administration of corticosteroids. Here is the incidence of hypocalcemia in cancer patients after receiving zoledronic acid 4 milligrams and also denosumab. You can see the higher rates are in prostate cancer patients at about 5.5%, and also in patients with small cell lung cancer, and also in breast cancer patients like these patients at about 6.2%. So what should we check before and during the anti-resorptive treatment in this kind of patients? We should assess the calcium homeostasis before, correct the plasma calcium, magnesium, and 25-hydroxy vitamin D3 deficiencies, have an assessment of the nutrition status of the patients concerning dietary items, let's say. We should control the renal function, and we should regularly and adequately supplement calcium and vitamin D. So in this patient, we gave her calcium citrate 1.2 gram, cholecalciferol of 1,200 units, and alpha-calcidol of 1 microgram per day.
I will give you a tricky question. Why calcium citrate, not calcium carbonate?
It's almost the same. It's almost the same.
No.
Never the same. Not the same, but
For renal patients, and whenever you're dealing with diabetes and any metabolic disease, it's better to give the calcium citrate. It is going to be absorbed wholly, while the calcium carbonate is diluted in the stomach and the gut. So you will get constipated, and like a patient like this, you will end up with failure. You will go up in calcium carbonate, but you will never have the levels as much as you want. So with an EGFR like this, it's better to give calcium citrate.
Okay, thank you.
And in the case of renal failure, it's better to give calcium carbonate because it's going to inhibit the absorption of phosphate from the diet.
But her phosphate was low.
Yeah, but it will sooner, when the patient develops renal failure, it will be a problem. Especially when you're giving an active form of vitamin D3, which is also going to increase the absorption not only of calcium, but also of phosphates.
We need a nephrologist.
What happened when she was given zoledronic acid?
yes, a good question. Serum calcium levels low, 6.7. But
After the zoledronic acid.
Case, yes, this was not the case, the differential diagnosis, but because this is a real case, yes, she came, the patient came with low calcium levels after the administration of zoledronic acid.
One would expect that. If she has osteoblastic metastases, then you don't go with zoledronic acid. First of all, you have to take care that you put her calcium levels to the upper limit of normal, at least. Give her a lot of active vitamin D, give her a lot of calcium, and then maybe give zoledronic acid if there is a rebound that zoledronic acid will inhibit osteoclasts, and then by coupling, maybe we can hope that it will. Otherwise, osteoblastic metastases should be irradiated, and with that, you reduce the activity of the osteoblastic metastasis and then go on with other procedures. Because I would expect that zoledronic acid would cause a severe hypocalcemia in osteoblastic metastases.
Yes. Oncologist gave the zoledronic acid, and then they ask our opinion.
To help,
so,
yes.
You can see this case report published, the whole story. But yes.
Correct me if I'm wrong. Also, the zoledronic should be given at low dose because there is a glomerular filtration rate lower. So
yeah, the limit it should be given slower because it was a chronic kidney disease stage 3, but it can be given because glomerular filtration was nearly 40, so it is allowed, but slower, with good hydration and so on and so on. Sorry?
At full dose?
Yeah, it could be given with a full dose.
So the question is, when are we going to check our serum calcium levels, or magnesium levels, or parathyroid levels after we give the zoledronic acid? And if we are going to check them?
In this case, or in any case that gets zoledronic acid? In this case?
In this case. And given that we have already substituted the calcium and the vitamin D, or 2 forms of vitamin D.
Yes. 1 to 2 days after the zoledronic acid? Yes?
Yes. 3 days, 3-4 days.
The calcium levels was Low, very low. So.
Yes?
So in most cases, zoledronic acid causes hypocalcemia during the first days following the intravenous infusion. And transient and asymptomatic hypocalcemia occurs mainly between 9 and 11 days after the first intravenous administration. So there have been also 4 cases reported with osteoblastic metastasis where hypocalcemia occurred between the 4th and the 11th day after the most recent intravenous dose. So the take-home message is that that we should check the plasma calcium in the first week after the administration of zoledronic acid, and afterwards also, if necessary. Thank you very much. Thank you.
Group 4. Very good cases. Good discussion. We are still aware and alert. It's
Where is the date case? Find it case.
That's right. Hungry stomach, not only hungry bone.
Case.
It's with a hidden. Okay, I will start and we'll find it in the way. Okay. Okay.
You will present. Your name is?
Yes, my name is Georgia Tsagaraki. I will try to be quick.
Thank you very much, Ms. Dr. Tsagaraki. Please go on.
Medication-induced osteoporosis. We have a case of a 75-year-old woman with severe persistent asthma requiring glucocorticoid therapy for the past 3 months presents for care. Her medication includes albuterol, inhaled fluticasone with salmeterol, montelukast, and prednisone at a dose of 10 milligrams per day. In the past, she received several intermittent courses of prednisone at a dose of 15 milligrams or more per day. So, how should we proceed with this woman? Ideas?
Does she smoke?
Yeah, we will assess the risk factors for this case. Okay.
Is she taking hormone replacement therapy?
No, she's not taking. She's menopausal. She's no HRT therapy.
Do you have PMD?
What?
Do you have PMD?
Great. Okay. Okay. Assessment of risk factors. We will ask her about δευτεροπαθή οστεοπόρωση, secondary osteoporosis. We will do the physical examination. She has a quite low BMI, in 18. She's rather short, and she has no pain in the back. Okay. So how should her case be evaluated? Managed to minimize the risk factor, the risk of fractures. Okay. Okay, we should do the DEXA scan, FRAX score, we should do the metabolism of the calcium metabolism, and what else? The X-ray, lumbar and thoracic spine. And
there is a
I think
comment.
Even if all these are normal, by what you said in your lecture, 3 months of over 7 milligrams of prednisone would be a sign to give treatment whatsoever.
Enough
for
we have
the
already
to introduce the treatment.
Yes, we have already a very major risk factor.
Yeah, but we are learning.
Yes, but
Let us
we
learn.
have to assess the other risk factors. Okay. So, who should be treated? We should re-examine that. FRAX score risk over 10% for major fracture and over 3% for hip fracture. Patient with osteoporotic fracture already. Patient older than 70 years old. If the dose is over 7.5 milligrams per day, and if T-score is lower than minus 1.5 at any site measured. So here is the DEXA scan for her lumbar spine and the femoral neck. Which side we prefer? Yes, but which side we prefer? for corticoid therapy and for FRAX. For cortical therapy, the lumbar spine we prefer it because the trabecular bone is the side that is most affected. So we see that we have the 4 lumbar vertebrae are rather good. There are no major malformations, so we have no artificial and we see that the total BMD, the total T-score is catastrophic, as you said. Then we can look to the BMD and the T-score in the femoral neck. It's not so it's not so problematic, but the lumbar spine. Yeah. No.
Yes, please.
2 things. One thing, the FRAX score does not necessarily need the T-score. So we can do the FRAX score without a T-score. The second thing is that
without measuring bone mineral density, definitely.
The second thing is that we always take into account the lower region. So if you have these 2, there is no question what you take. You take the region, which is the lumbar spine.
Yeah, and the lumbar spine shows us that this patient had been on glucocorticoids for a long time because they affected especially trabecular bone, which is in the lumbar, measured
especially
in the lumbar
Greece,
spine.
if we have one place that we can measure, we will prefer the lumbar spine.
Yes, but in this case, we didn't do the FRAX score. We will just show the FRAX. It's enough. She has so many indications. We are just repeating what are all the indications that she has to be treated for GEOP, of course.
Okay, so I can carry on now. The assessment of the fracture risk, the risk factors. It's just an overview.
Go on.
Yeah, you're all acquainted with that. Okay, so.
Go on. Yes.
The FRAX score. Yeah, but I am following her guidelines. Okay, she has vertebral fractures because you will have over 20% reduction in the vertebral height, so we have it as granted. Of course, I told you that she was a rather short lady. We have it from her history that she has decreased height. So we have another indication of her osteoporosis. Yes, yes, yes. She has so many.
Another indication. She has many indications.
So many
but
factors.
So we review all the
Yes.
indications.
Exactly. A very simple case, just to repeat, because it's the end of the day.
Go on.
Okay, so she has so many factors. Okay, we're all listening for it. But what else should we do in a case like this? So, should we not examine anything else? Yeah. Yeah. Very right.
But in primary hyperparathyroidism, we would have low distal radius and low femoral neck.
Cortical bone. Cortical bone. Yes.
The problem
But
is that there are no normative data generally, so it's a little bit difficult to use the radius data. We don't have normal data. There is
Yeah,
normally
but you
data
have
from the
T-scores. You have T-scores.
I think that you need
Mike.
I think that you need the PTH because this patient has such a bad osteoporosis that maybe teriparatide should be the first treatment. So maybe you have to have a PTH so that you can treat with teriparatide.
If calcium is normal, phosphate normal, alkaline phosphatase normal.
We may have secondary hyperparathyroidism due to hypovitaminosis, and then we cannot take teriparatide according to our SPC and the rules that govern the use of teriparatide.
Okay, but her calcium was totally normal, phosphorus was totally normal, and alkaline phosphatase was normal because the fracture was old, not new.
And the other thing is that if you only measure PTH levels, she will probably have them increased because she will probably have also vitamin D3 deficiency. So I would agree with you, measure calcium first, and if it's normal calcemia, don't measure PTH.
Okay, I could measure the creatinine to assess the renal function, alkaline phosphatase to assess the vitamin D deficiency, yeah, TSH as well said, electrophoresis for multiple myeloma.
Yes, because in
and
multiple myeloma we will also have impaired bone mineral density in the vertebra, more than
assess the status of the androgens, especially in men, okay? And, of course, an X-ray in thoracic and lumbar spine. And if we have the alternative to assess the
vertebral fracture assessment by DEXA.
Yes. And see again how should glucocorticoid-induced osteoporosis be treated by oral by bisphosphonates, intravenous bisphosphonates as zoledronic acid, teriparatide, and denosumab every 6 months, and caution in immunosuppressed patients, and she is an immunosuppressed patient, we suggest, because of the glucocorticoid.
Please.
May I ask, perhaps both of you, since you're there, we routinely get patients with Graves' orbitopathy, and they need intravenous steroids, which they take for 3 months, at a total dose of 4.5 grams of methylprednisolone. What is your practice? Do you think they should receive prophylaxis with bisphosphonates?
What is intermittent? What is the time?
Once a week.
Yes. 3 months, over 3 months, weekly, over 3 months. Well, also.
Yeah, I know. It's a huge dosage, but apparently they say that there is enough time in between two dosages that the bone recovers. So it's not so deleterious as to give glucocorticoids each day. But it's not 100% sure, as anything is 100% sure in medicine, and we should maybe think about protecting the bone, especially if somebody is at higher risk, close to the levels where we would anyway give some treatment.
Already,
please.
Already, it's not, although it is not clearly defined in the guidelines, I think that we do not do anything bad to our patients if we advise dietetic calcium intake, a high dietetic calcium intake, and also depending also on the time of the year, vitamin D supplementation, 1,200. Depending also on because these patients, they are usually hyperthyroid, they have an increased turnover of the bones, depending also on how long the whole process goes back. And so, well, I don't think that it is, and if Maria also agrees that to advise vitamin D and calcium dietetic intake.
Yeah, and it's true, because hyperthyroidism goes with a very high bone turnover, and states with high bone turnover are more prone for fractures. So we have
exactly.
To take
that's what I want to say.
account.
I would worry more about fracture, the aseptic fractures in these patients with a high dose of corticosteroids instead of osteoporosis, future osteoporosis. The high risk they have is the aseptic fracture in the femur. And you can't do anything about it, but the only thing is vitamin D and calcium protection, nothing else.
But still the data for the high dose, they exist that when you give a high dose of steroids, then you've got increased bone markers. But as you said, there aren't long enough studies following up all these patients to see what happens long term with these patients. So I think the literature is inconclusive about what you should do with these patients. And probably you take into account the other clinical aspects of the patient for your final decision, but it's not well evidence-based.
Not well defined.
Although bone markers are coming up very quickly, even with one daily dose of 40 milligrams of prednisolone, the bone markers, they are coming up, they're increasing.
Yeah, but they then drop down until the next dosage.
Thank you. I asked
but
for
still,
2 and I got 4 expert opinions.
There is not definitely said already the lower dosages of prednisolone increase the risk of fractures, and intermittent prednisolone, so every other day, also increase, and nasal inhaled glucocorticoids can suppress the pituitary, hypothalamus-pituitary adrenal axis and can increase fracture risk. So with glucocorticoids, it's very tricky. And then another factor that we have to take into account, people have different glucocorticoid receptors. So the susceptibility of the receptors is very different. Some are resistant, some are very sensitive. So each same dosages will cause more harm in one person as compared to another one. So we are always on a slippery ground, and we should always think about what is better for our patient and to give medication earlier than too late. So,
Dr. Tassopoulos, please.
If you allow, I have one question and one comment. The question is, there has been a tendency to exclude the first lumbar vertebra for its normally small size from the calculation of the mean. Do you think this is correct to use the 2, 3, and 4, or do you normally consider the very small lumbar one? Does it add anything better?
Many years ago, we used L2 to L4. exactly as you say. But now it's used L1 to L4. I don't know why. But then you have four vertebrae, and when you measure again, then you can compare more places where you've measured, and you see the changes easier. I think it's the reason.
There are two ideas. The comment is that it may sound strange, but in the sunny Greece, there are a lot of old patients, old age patients, who are very severely D3 deficient. So measuring D3 and parathormone, even with normal or high normal calcium, it's not a crime, because if the parathormone is quite high, we cannot use the riparatide by the Greek law.
Yeah, exactly. By Slovenian law as well, but any common sense not. You're right. And measuring vitamin D in patients in whom you really suspect they are vitamin D deficient. For instance, probably these old Greek people, they don't go outside into the sun. So in everybody in whom you, by the history, suspect that they are vitamin D deficient and so severely vitamin, you have to measure it, because then you have to start with replacing with very high dosages at the beginning for a few months, and then go down to normal
and the
dosages.
vitamin D3 deficiency responsible for secondary hyperparathyroidism is quite often in Greece.
Okay, I believe you. Yes,
Last
in
comment.
old people. Yes.
I will add something, that if you have old Greek women suffering like that, we have Lebanese young people suffering of that, because they are veiled, and moreover, they are ceasing to have any dairy products whenever they're 7. About issues about coming halal and other things. And that's why we have a very young counterpart of these patients having fractures under the age of 45.
But please let Dr. Tsagarakis make conclusion and the final statements.
Okay.
She has posed some questions there.
So, how can we proceed with the patient? How can we treat her? Any ideas? All of these? We treat her. Which of these? Which?
All the guidelines suggest the first line treatment is oral bisphosphonates for many reasons. Also the price. And then we can choose further if she's intolerant, if she has some problems with reflux or whatever, and then so on, and then it goes down second choice, third choice, fourth choice, and fifth choice. And we are hungry, we should eat our dinner.
Well, thank you very much.